Hello, everyone, and welcome to the CareQuest Institute for Oral Health Continuing Education webinar. My name is Francesca Gattuso, and I am a member of the education team here at CareQuest Institute. The webinar topic for today is on the Healthy People 2030 Oral Health Objective webinar series. Next slide, please. Before we start, I'd like to share some housekeeping items. All lines will remain muted to avoid background noise. We'll share a copy of the slides and a link to the recording after the webinar concludes. They will also be available on the carequest.org website under the Education tab, Select Webinars. If you would like to receive a CE credit, we kindly ask that you complete an evaluation form. We will send a link to the evaluation form by email within 24 hours. Complete the evaluation by Friday, October 28th to receive your CE credit. You will be emailed your certificate shortly after that. Your feedback is always greatly appreciated, even if CE credits don't apply to you. Next slide, please. You can add questions to the Q&A box throughout the presentation, but know that we won't turn to questions until the last 10 to 15 minutes of the webinar. We will do our best to answer your questions at that time. Next slide. Now I would like to introduce and pass it off to today's moderator, Rear Admiral Timothy Elbricks.
Thank you, Francesca. Good morning, good afternoon, everyone. Thank you all for joining the second webinar in our Healthy People Oral Health Promotion webinar series. We'll be doing this over the next 5 years or so, and we will be engaging external partners, federal agencies, to help promote and raise awareness of the 11 core oral health objectives in Healthy People 2030. Today's webinar is entitled Reducing the Proportion of Adults with Untreated Tooth Decay. And our partners for today's call are the CareQuest Institute for Oral Health and the Indian Health Service Division of Oral Health. Next slide. So this is our standard disclosure. None of the speakers or moderators have any disclosures to report related to the presentation. Next slide. And here are our learning objectives. At the conclusion of this webinar, you should be able to explain what Healthy People 2030 Oral Health Objective 0H-3 is. You should be able to describe disparities in access to care and untreated tooth decay by race, ethnicity, and income. You should be able to define oral health literacy and describe its impact on access to care and untreated dental caries. And finally, implement at least one oral health literacy activity in your community to address this oral health objective. Next slide. So this will be an hour-long webinar, and we will have 4 different parts. I'll provide an overview of the Oral Health Objective 3, and then we have Dr. Alice Horowitz, who will talk about why oral health literacy is important for all Americans, followed by Dr. Catherine Atchison, who will talk about health literacy as a key factor in integration of healthcare. And it will conclude with Dr. Jay Kumar letting us know about the California Oral Health Literacy Toolkit. We'll have a short Q&A session moderated by Captain Nathan Mort from the Indian Health Service, and then we'll provide a short summary and announce the next webinar in this series. Next slide. So let me introduce our speakers for today. First is Dr. Alice Horowitz. Dr. Alice Horowitz is a research professor and recently retired from the School of Public Health at the University of Maryland. Formerly, she was a senior scientist with the National Institute of Dental and Craniofacial Research, one of the 27 institutes of the National Institutes of Health, and her research focus has been on dental caries prevention and early detection and prevention of oral cancer. She was instrumental in initiating the need to address health literacy in dentistry. Our next speaker after her is Dr. Catherine Atchison. Dr. Atchison is Professor Emerita at the UCLA School of Dentistry and Fielding School of Public Health. She was also the section editor for Section 4 in Oral Health in America and lead author on integrating oral health, primary care, and health literacy considerations for healthcare professional practice, education, and policy, which was commissioned by the Roundtable on Health Literacy, Health and Medicine Division for the National Academies of Science, Engineering, and Medicine. Our speaker after that will be Dr. Jay Kumar. Dr. Jay Kumar is the State Dental Director at the California Department of Public Health. He is a board-certified dental public health specialist and former president of the American Board of Dental Public Health. And then our moderator will be, for the question and answers, will be Captain Nathan Mork. Dr. Mork is an oral health promotion disease prevention officer within the Indian Health Service Division of Oral Health, and he serves on the Indian Health Service Health Literacy Work Group. Next slide. So let me start by giving an overview of this Oral Health Objective 3. Next slide. So this specific objective reads as follows: to reduce the proportion of adults 20 to 74 years of age with active or untreated tooth decay. So our baseline at the beginning of the decade is 22.8%, meaning 22.8% of adults 20 to 74 years of age had active or untreated tooth decay. Our target by 2030 is 17.3%. Next slide. What we know is that untreated tooth decay, there are disparities based upon race, ethnicity, geography, and income level. This bar graph shows the differences we see by race and ethnicity. So as you can see, with the yellow bar, non-Hispanic Black Americans suffer disproportionately from untreated tooth decay, with almost double the proportion of non-Hispanic White Americans, which are the orange bar at 21.4%. Next slide. When we look at income level, those who are living below 100% of the federal poverty level, that's the yellow bar, and the federal poverty level is currently around $25,000 for a family of 4, they suffer disproportionately compared to those living at 100 to 200% of the FPL, the blue bar, and those living at 200% or greater of the FPL, with almost 2.5 times the prevalence of untreated tooth decay between those living in extreme poverty compared to those at 200% or more of the FPL. Next slide. So we often say that untreated decay is closely associated with access to dental care. And to that effect, this is a map of designated dental health professional shortage areas. All of these areas that are colored in pink or various shades of purple are designated dental HIPSAs around the country, and there are over 60 million people that have access to care issues in these health professional shortage areas. Next slide. And then remember, I just showed you untreated decay rates by race and ethnicity. It does closely align with access to care by race and ethnicity. Non-Hispanic Asians have a much higher access rate than non-Hispanic Blacks and Hispanic Americans. And of course, non-Hispanic White Americans, the green bar, have the highest access to care. And these are for adults. Next slide. So what I want to do, though, is to tie untreated decay into health literacy, oral health literacy. And as you may or may not know, October is Health Literacy Month. And here are just a few facts about it. More than 40% of Americans have difficulty planning, obtaining, processing, and understanding basic healthcare and oral healthcare information, which is not only necessary for making informed decisions, but also necessary to be equal partners in their healthcare. We know that lack of healthcare literacy hampers global healthcare, also healthcare in the U.S. Each year, October is designated as Health Literacy Month, and this began in 1999 by author Helen Osborne, who wanted to increase access to healthcare information. So as I talk about this, I'm going to segue into Dr. Alice Horowitz, next slide, who's going to now talk about what oral health literacy means and why it's important for all Americans. Dr. Horowitz.
Thank you very much, Dr. Ricks. With that, next slide, please. So first, what I want to do is to give you a little background on the definitions for health literacy. And it was first defined in the US by two physicians, Ratson and Parker. And that was done in about the year 2000. And it's the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. This definition is largely taken from the World Health Organization's definition. You can cross-check that, but it's very similar. Next slide, please. By the way, in the Healthy People 2010, which was published in 2000, was the first time oral health literacy was in print and included. And all it did was insert the word oral before health. But that's where that actually began. But today, for the 2030 objectives, we finally got off focusing only on the individual and now look at health literacy as both personal health literacy, and that's the degree to which individuals have the ability to understand and use information and service to inform health-related decisions and actions for themselves and others, whether it is a parent helping the child or a child helping their parent. And a broader category is organizational health literacy, which is the degree to which organizations equitably enable individuals to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. In other words, what we're asking for organizational health literacy is just how user-friendly are they? Next slide, please. So why is oral health literacy so important? Next slide. Low levels, we know based on research that low levels of knowledge and understanding are a result of low level of health literacy. And we know that there are fewer dental visits by those with low level of health literacy. And there's an increased severity of dental caries, higher rates of failed appointments, lower oral health related quality of life, and lower use of preventive regimens. This is a big ticket item. Next slide, please. So the problem is all too often, oral health is not considered important. The majority of people don't even understand that, the head is actually connected to the body. And it is because of that we have virtually a neglected epidemic regarding oral diseases. The 2003 National Assessment of Adult Literacy, the only national survey that has been done in the US, showed that 22% of US adults lack basic prose literacy. So they're unable to read and understand, much less apply information that we need them to know about how to prevent oral diseases. So oral health literacy is inextricably linked to improved oral health. And in increasing oral health literacy is essential to achieve health equity. We simply cannot have health equity if we don't increase oral health literacy. And increasing oral health literacy is essential, in my mind, to reach the 2030 oral health objectives. Next slide. So how to reduce this percentage of adults with untreated tooth decay? This is critical, and very importantly is we need to educate the public, all provider groups, and policymakers how to prevent dental caries. That is, we want to increase their oral health literacy about appropriate fluoride use, about dental sealants, that the need to reduce sweets between meals, although frankly, I think that's a tough one to try and do, and to have regular dental appointments with a dentist. Next slide, please. And so just to remind everybody, in case you don't have a dental background, that primary prevention of dental caries is that the best way to do this is the appropriate use of fluorides and the use of dental sealants. And we have known this for decades. Look at community water fluoridation, which has been around for over 70 years. And community water fluoridation is the foundation for caries prevention. This is for children and adults. We need to use that. Over 70% of U.S. municipal water supplies are optimally fluoridated, yet many do not drink the tap water for various reasons. We've done studies that suggest that not only do individuals think it tastes bad, looks funny, but also among lower income individuals, we've had responses that indicated, well, everybody else is drinking bottled water, and we want to be like everybody else. In other words, they don't want to be different. And yet, think about what those plastic bottles are doing to our oceans, and that the individuals are not getting optimally fluoridated water when they could. Further, in my perspective, that only minimal efforts have been made to educate the public about the benefits of community water fluoridation. We can't just, send out a message once and then say that, that's it. We have to continue and repeatedly, because we have new immigrants, we have new parents, we have people who simply don't know that that fluoride in the tap water prevents tooth decay, and get it from the tap, use it. Next slide, please. So other ways that we need to do to reduce untreated tooth decay among adults is to educate policymakers about the impact of oral health on general health. All too many simply do not recognize the connection, and that we could save a lot of teeth, a lot of time, and a lot of money by having policymakers know what it's all about and that they do something about that information. Further, we need to ensure that Medicaid and Medicare insured adults are provided dental services. And a few states are working in that direction. And we also need to ensure Medicaid process, the application process, uses core health principles. That is, that they don't use plain language and no jargon is used. This we have to work on. And of course, there was the Plain Language Act from 2010, but how well that's being enforced, I'm not sure. But we need to really work on that. And incredibly important is that we increase Medicaid fees to private practitioners so that they will accept these patients. Further, we need to educate the public, especially those with low levels of education, about the impact of oral health on general health. And we learn more and more about that. It's very, very important that we do something about it. We need to educate non-dental health providers about the impact of oral health on general health, and because we need their help. And my colleague, Dr. Atchison, will go into that further. Next slide. So lack of oral health literacy among oral health providers is a barrier to increasing health literacy and oral health. So if integrating oral health then into general health is a given, we must do that. Next slide. So just as a quick, but I know more time is going to be spent on this aspect, but it's important that we as health providers listen carefully to what our patients have to say, that we use teach back to confirm what we think we've said to our patient, and then that is what they have heard. Could be a big difference. Also, we need to ask patients to tell us what they will do at home to follow the instructions we have provided. We need to slow down, use short statements, use plain, non-dental, non-medical language. Why use the term radiograph when we can say x-ray, or why use the word periodontal disease when we can say gum disease? We also could use visual aids or how to draw and show pictures when it is appropriate. And I believe Dr. Kumar is going to get into more of this. And now I would like to turn it over to Dr. Atchison.
Thank you, Dr. Horowitz, and good morning, everyone. It's really a pleasure to be here this morning to talk about reducing the proportion of adults with untreated tooth decay using health literacy as a key factor in integration of health. Next slide, please. In 2004, the Institute of Medicine produced a health literacy framework that showed how health literacy sat at the heart of connecting the healthcare system, societal expectations, the patient's culture, and the educational system that prepares health providers to learn to work together. And through that, also the K through 12 education system, because that's the group that will educate youth on what are considered major health needs, which we hope would include oral health. These three systems produce the information that the population knows about the health system and how to interact with it. And bringing these intervention points together helps to determine the country's health outcomes, including dental caries and the cost. Next slide, please. Dr. Kleinman, Horowitz, and I revised this framework a couple of years ago based on the premise that successful integration of oral and general health is critical, and it's enhanced by health literacy. A patient's health conditions, including oral health, relate to the broader environment, the community's needs, available care services, and the roles played by the individual, the healthcare providers, and health policymakers. Both health and health literacy in this model are in the center with a permeable membrane between them. Health literacy is a determinant of health, and lower health literacy is associated with poor health outcomes, such as early childhood caries. Also with health disparities, poor access to care, and increased cost of care. The confluence of poor health literacy and lack of integration can impede health equity, and we're seeing that in our country. Next slide, please. Let's look at some integration examples and why they're relevant to this discussion of improving oral health. Preventive oral health services can be provided by medical providers within clinics. We've seen that medical providers can provide preventive oral health screening, fluoride varnish, periodontal care, and referral for pediatric patients, pregnant women, and other patients with chronic diseases. Why is this important? Regular periodontal treatment has shown decreased overall cost of care, and if it's left untreated, it will continue to get worse. So integrating with our medical providers to make sure that they are looking for this and referring people to the dentist is a very useful thing to do. The social determinants of health, such as lower level of education, lack of usable insurance, etc., are associated with the lack of health care access. Next slide, please. Simply changing the location one may receive services, oral health services, is another way to bring people into our care system. Dr. Ricks showed us the huge number of HIPSAs in the U.S., and it's very relevant because particularly in rural areas, there are many areas that don't have oral health providers. So services can be provided in non-traditional settings, such as community clinics, K through 12 schools, or hospital settings to better serve patients with lower health literacy and through integrated services. Dental hygienists or dental therapists can clean children's mouths in school and in Head Start programs. We can have them, pregnant women in primary care clinics and in dentally trained hospital staff are currently cleaning ventilator patients' mouths in order to prevent pneumonia. Why is this important? The studies of social determinants of health show that many Americans do not have access to dental offices for ongoing care. Therefore, accessing people where they are can bring people into the care system. Next slide. Dentistry has lagged medicine in the use of case management and coordination of care, which are both health literate services. When you think of, we're hearing more about the dental home or the medical home, and these are services which are part of the medical home in order to make sure that people, it's a health literate process to make sure that people understand what they need and where to find it. Providers such as nurse coordinators or community dental health coordinators and others can use manual and electronic tools such as the electronic health record to enhance care coordination with a purpose to get people into the healthcare system, to coordinate the providers across the patient's care system, such as physicians and dentists, and to reduce the use of the emergency department. And why is this important? Diverting people from the emergency department to a primary care dental treatment is important to educate people about what they need to receive and where they can receive dental care locations. Next slide, please. Preventive medical services offered by dental providers. Dentists, dental hygienists, and CDHCs can screen and refer for medical services. So this is not a one-sided integration. In practices where accountable care organizations, the structure of the insured services has changed, and dental providers, such as dentists or hygienists, etc., screen the patients, and they can make sure that the patients are getting their preventive services by looking at care gaps and refer for medical treatment. In some states, they even offer HPV vaccinations. The overall goal is to improve oral health outcomes and decrease the cost of care. And this is being done. Why? Because preventive care is emphasized and it can decrease this cost of care. So that's important. Next slide, please. The health insurers have added dental benefits to some of the medical plans, which is a newer modality for further integration of care. So when you look at accountable care organizations, they offer selected preventive dental services, such as semi-annual or quarterly periodontal cleaning, oral exams. And because this has been shown to increase direct patient-centered communication, and it can improve the overall care, they have really added on the integration from the medical side. Dentistry is a smaller part here, and it's less involved in unilaterally pushing for integration. But because this has been shown to be valuable for chronic care patients, periodontal quality metrics are now available for diabetic patients, and adding dental benefits has decreased the overall cost of care, usually in lowering the hospital care by confirming the importance of dental services. Next slide, please. So in summary, the healthcare system has expanded to embrace health literacy, and it's doing this in part through growing integration of care, better use of direct patient-centered communication, the public and professional education systems, and the public health system and the healthcare system. And dentistry is involved, but it is primarily involved through corporate and public health systems, and less so via private practice, because there is less ongoing interaction between physicians and dentists in private practice. Thank you very much. And I'd like to turn this over to Dr. Kumar. Oh, these are our references, so if you want to check anything out, you can do there. Thank you. Dr. Kumar.
Thank you, Dr. Atchison. Good morning, everyone. My role today is to give an overview of this digital toolkit that the California Department of Public Health Office of Oral Health produced recently. We've been working on this project for about 3 years. It started with a recommendation by the California Dental Association's Access to Care report. And this is one of the strategies recommended in their plan. So this is a new digital resource for oral health care providers to help them to learn and review the basic principles of oral health literacy, including the importance of communicating clearly and with cultural humility and creating a welcoming environment for patients. Next slide, please. Next slide. So I want to take this opportunity to acknowledge the contribution of many, many people in producing this toolkit. We contracted with the Health Research Action Team at UC Berkeley and also with the UCSF School of Dentistry Oral Health Technical Assistance Center in disseminating this toolkit. Our special thanks to Dr. Linda Newhouser, who was the PI of this project. Next slide, please. So as you can see, there are 6 health literacy-related objectives in Healthy People 2030. And out of the 6, 4 of them are related to communications by healthcare provider. For example, the first one is increase the proportion of adults whose healthcare provider check their understanding. The second one is about decreasing the proportion of adults who report poor communication with their healthcare provider. And the third one is about increasing the proportion of adults whose healthcare providers involve them in decisions such as much as they wanted. And another one is about increasing the proportion of adults with limited English proficiency who say their providers explain things clearly. Next slide, please. So the California Oral Health Literacy Toolkit project had 3 objectives. And the first one was to conduct background research about oral health literacy nationally and in California. And the second one was to develop a practical toolkit and trainings to support California dental providers. And the third objective was to advance oral health literacy in dental settings and local oral health programs. When we were looking at oral health literacy initiatives, we could not find a toolkit for dental settings. There is one developed by AHRQ for primary care providers, and that's a very lengthy document, and the setting is different because the primary care offices usually they are fairly large in size compared to the dental offices. Next slide, please. So for this project, the Health Research for Action at UC Berkeley carried out a study to assess the current status of oral health literacy knowledge, guidelines for practice, and resources for dental providers in California. It helped to identify the most effective approaches for dental teams, and also to examine gaps in the literature and practice guidance, as well as to assess patient materials to inform the development of statewide training and resources to improve dental teams' communication with patients about oral health across California using best practice for oral health literacy. So to achieve this, we conducted several studies in phases. The first one was a literature review of materials that are currently available. So there are no systematic reviews about oral health literacy materials at this stage. And the second was an environmental scan of existing reports, training materials, education materials, and guidelines. And third one was to adapt oral health literacy training to specific groups of dental team providers. So HRA conducted a series of qualitative interviews of California dental providers, dentists, dental assistants, administrators, and assessed their providers' background knowledge about oral health literacy, and also about their current practices, their interest in training, and their preference for training delivery and resources that was needed. So these three parts came together to paint a picture about what the current resources and that are available, the understanding and the needs for oral health literacy among dental providers. So that led to the California Oral Health Literacy Toolkit. We found that in general, there was low use of recommended patient communication strategies in dental settings. And also we found that there are limited oral health literacy training and opportunity for training. Next slide, please. So we outlined 4 steps for a more health literate practice. So the first step in implementing health literacy is to choose someone to lead the efforts in a dental office or in a clinic. A team leader will help identify areas of improvement and develop a plan for change. It helps to pick a team who is working closely with patients and has an interest in health literacy, has authority to change office procedures and patient experiences. And the second step is to raise awareness. All providers and staff should incorporate health literacy principles into their workflows. This requires raising awareness among providers and staff about oral health literacy. The next one is about providing patients with plain language materials. And the final step is to monitor progress in applying the oral health literacy principles and making adjustments in dental practices. Next slide, please. So this is the Oral Health Literacy Guidebook. It's available digitally and anyone can download this material. It's a 24-page booklet and that it provides orientation to elements of oral health literacy. It offers a roadmap for practice assessment and planning improvement, and it includes communication techniques, language access resources, patient-friendly practice tips, as well as some scripts and templates. Next slide, please. So the toolkit consists of a checklist to assess the readiness of the office in a systematic way. So there are 4 domains here. The first one is preparing for change. And the second one is creating a health literate environment. And the third one is communicating with patients. And finally, it's about empowering patients. So there are 28 items in this checklist. So this will help an office to understand the gaps in their practice and develop an action plan. For example, in order to prepare for change, one has to identify a team or a leader, a literacy team and a leader, and then practice has an oral health literacy action plan. Staff understands the impact of oral health literacy. Each staff member understands their role in health literacy. Each staff member understands their role in the action plan. So staff has received the health literacy training. So this checklist has items like these throughout. And one can assess where the office stands with respect to these items. Next slide, please. There is a special emphasis on the teach back method, as this concept is new to many dental offices. There is a printable one-page tip sheet. It includes reminders for practitioners and staff on how to use TeachBack. There are scripts, but we have learned that many dentists want more scripts. We haven't found a good dental related TeachBack video, for example. There are several on the medical side, and there are TeachBack videos about scheduling appointments. So this is applicable not only for clinicians, but also office staff in general, whether it is front office or back office. So all of them can use TeachBack method in their practice. Next slide, please. So the next item we have here is about making a plan. So there is an action plan template. It's a convenient place to record oral health goals and action items. It complements the oral health guidebook. So this template helps to set short-term and long-term goals and decide what areas of practice one wants to improve. For example, in a diverse state like California, an office may want to offer more language services or begin having providers and staff use the TeachBack method. So, and in general, creating a healthcare literate practice takes time. So each provider and staff member should have clear role and a set of tasks. And it helps to discuss these roles to determine who is best suited for each task. Tasks and processes are clear and visible to and easiest to perform. Some new skills such as using TeachBack method can take time to learn, and it, with the practice, it can be improved. It can be difficult to measure the impact of health literacy on patient outcomes. So we suggest in this guide that dentists should consider measuring patient satisfaction and even things like appointment cancellation rates and what action dental office can take to address those. Next slide, please. Separate from the toolkit, we have created websites, not only at the Office of Oral Health, but also in collaboration with UCSF School of Dentistry, Oral Health Technical Assistance Center. So you can access all the resources through this website. So it is posted on the website. In addition to Oral Health Literacy Toolkit, this website is designed to assist local oral health programs in implementing community water fluoridation, school dental programs, in supporting tobacco cessation counseling in dental offices, and in promoting sugar-free beverages. So there is a guidebook for, it's called Sugar is Not So Sweet. We collaborate with Alaska Dental Society and the Department of Health there, and we adapted their toolkit for promoting sugar-free beverages. Next slide, please. So the California Dental Program, we collaborate closely with them, and they have created a patient-facing website called Smile California. It's a campaign, and it consists of a variety of resources, including videos on topics such as sealant, preventive dental visits, back to the school checkups, oral health care during pregnancy, oral health care for seniors, so on many more topics. It also includes directions for finding dentists. There are videos and there are materials for partners and as well as for providers. So this is a very robust website with many, many resources for Medicaid beneficiaries, and not only for benefit, others can also use the materials for improving their own health. Next slide, please. So in closing, I'd like to propose 4 initiatives to advance oral health literacy. This will require federal and state partnerships. And the first one is about evaluating projects to determine what works to improve oral health. There's a need to develop questions for national and state surveys. There are many national and state surveys, for example, behavioral risk factor surveillance for adults. There is a survey for pregnant women. It's called PRAMS, and in California, it's called MIHA. So there can be oral health modules that, and those modules can be modified to include some questions about oral health literacy. And another one is about developing performance measures. So there are clinical performance measures for federally qualified health centers. And I think it is time to look at a clinical, a non-clinical measure, performance measure, one related to oral health literacy. And especially because there is need to develop a performance measure regarding social determinants of health, and also supporting and training of FQHC staff. And finally, exploring the feasibility of learning collaborative for state Medicaid dental programs to promote oral health literacies. So there are several learning collaboratives for state Medicaid dental programs. And so this can be another one related to oral health literacy. Next slide, please. So at this time, I want to pass it back to Dr. Tim Ricks. Thank you.
Thank you, Dr. Kumar, Dr. Horowitz, and Dr. Atchison. We had a lot of questions that were submitted either through the chat Q&A or even texted. And so we'll only have time to probably get to 2 or 3 of these. But I'll ask the panelists to look at the Q&A especially, and if you can answer any of those, do so. But I'm going to turn it over to Dr. Nathan Mort from the Indian Health Service, who will moderate the questions for the panelists. Dr. Mort.
Thank you very much, Dr. Rick. So we'll start with the first question, and that is, how does oral health literacy relate to untreated dental decay among adults? And would any of the panelists be interested in answering that?
Yes, I'll take a stab at that. But first, I would like to ensure that everybody understands that the need to increase oral health literacy is not just focused on this age group, but it should be from pregnant women and throughout lifespan. And this is critical in my mind, that oral health literacy is for all of these. And most of the answers would be for the same age groups. Individuals cannot prevent tooth decay if they don't understand how to do it, when to do it, and actually do it. So this is critical that they have those tools and understandings. Then when they already have decay, obviously they need to know how to get treatment. And this is going to be dependent on whether or not they are Medicaid or Medicare, and how easy it is to work with those agencies within their state. But knowing all these things is critical to being able to stop this decay. We know how to do that, but we haven't shared that information with all of the population.
Thank you very much. Excellent response there. The next question that I have is, what is the role of organizations in promoting integration? And that sounds something like Dr. Atchison, you spoke to the organizations and integration. So would you be able to take that response?
Yeah, thank you. I'd like to take a stab at it, and I'd like to actually consider to some extent the questions that are in the chat on this question, because I think that organizational health literacy requires the dental team as one mini organization, but also the broader area in which, if you'll think back to the slide, we proposed there was the element of the the dental team, the broader, what is being promoted by the education system, by the healthcare system within states and nationally, and what we're really teaching people, because they don't learn this innately. And so I want to, maybe I'm criticizing, but I'm going to suggest that we could improve each of these if we were to work at it. So first of all, within the dental system itself, there's roles for the dental team within their part of the organization to play a role in not only health literacy, but also integration of health. So within the office, the dentist should be trained to check for the use of health literacy checks by the dentist, by the dental hygienist, by the front office staff, and confirm what the patients heard and what they think that they need to do next with their own health. The front office staff has an important role because it's been shown in the literature that most people don't understand their insurance. So if you have insurance, that's great, but you need to know how to use it. So the front office staff should be trained to review their insurance with them and make sure that people are aware of what to do and what they really have coverage for. Encourage them to set up return hygiene visits, set up what they need to have done, etc. And then the other system that I mentioned in our integration part as an organization is the education system from K through 12. And we know that school nurses are there, but there's very little done in the education system as one of the major organizations to encourage discussion of oral health within the schools. I had a dental student, who was interested in knowing how much there was on schools within LA Unified. And we did a study looking at that, and we found we actually had people who wanted to talk to us, and they said they were nurses, they were in some cases dental hygienists. They said, we know it's a problem, but we don't have any allocated hours by the California state to do oral health education. So they said, if you want to develop a curriculum and come in and teach it, we will give you a couple of hours. But they were not willing to take on any role in developing oral health program to teach within the K through 12 system. And that's a problem, because that means that young people are not learning this information. Okay, so I think that covers some of the aspects that I think are important.
Thank you so much. That's a great answer. And probably the final question here: how can the dental teams, dentists, dental hygienists, dental assistants, office managers, etc., play a role in oral health literacy? And that sounds like something Dr. Kumar.
Thank you, Dr. Mork. Every team member has a role, and that depends on the setting. For example, Dr. Lindsay Robinson in California is a leader, is a champion, is one of our champions. And in her office, the leader for ensuring oral health literacy techniques are implemented is a dental assistant. And similarly, in some of the other offices, front office people have played a significant role, and they can play, a role in creating a friendly environment in a dental office. They can make sure that all the signage is in plain language, all the materials are easy to read, and make it available in multiple languages. And also clinicians, you can use oral health literacy techniques in communicating using plain language, visuals and drawings, and teach-back methods. So every team member has a role. And now in California, for example, community health worker benefit is part of the Medicaid program. and dental teams can collaborate with community health workers and educating the community, because that's one of the roles that they can play. Thank you.
Thank you very much. And with the amount of time that we have left, I'm going to turn it over to Dr. Ricks.
Thank you,
Thank
Dr. Mork. Dr. Horowitz, did you have, you have your hand raised. Did you want to
do. Thank you. I just wanted to add, because none of us have mentioned it, I think, to any extent, but the use of after visit summaries to provide additional patient information is so critical and pivotal. And this is most likely to be available like in HMOs as well as federally qualified health centers when they're using electronic health records, and to have it verbally said to a patient and then followed up with the same words in print is highly, highly useful. Thank you.
Thank you, Dr. Horowitz. Next slide, please. So in summary, again, oral health objective 3 is to reduce the proportion of adults ages 20 to 74 years with active or untreated decay. And our federal oral health work group came up with several broad strategies to address this objective. One alludes to what I mentioned in the very beginning, and that is improving access to care, since we know access and untreated decay are very closely related, especially in minority populations, those living in poverty, and those living in rural America, using an integrated model approach. In other words, using the entire healthcare team, not just oral health providers. Number 2, increase the use of topical fluorides. And when we're talking about untreated decay, we're talking about things like silver diamine fluoride in older adults through increased education, access, and application by even other healthcare professionals outside of dentistry. And third, work collaboratively within your organizations, within your clinics, within your private practices, with non-dental colleagues and your dental colleagues to improve oral health literacy. Next slide. So as I mentioned, this is the second in a series of webinars. If you missed the first one, we'll send that link back out through our various listservs. That was held in August. Our next one will be November the 16th at 12 o'clock Central Time, 1 o'clock Eastern, and we'll be focusing on reducing the proportion of adults with moderate to severe periodontitis. And our partners for that call will be the American Academy of Periodontology, the American Institute of Dental Public Health, and the Veterans Health Administration will be the one moderating the questions. So with that, next slide, I want to provide you with resources for Healthy People 2030. There's a toolkit that is available on healthypeople.gov, and all of these other links as well. And I believe these slides will be made available, and this is being recorded, this webinar. I'd like to thank the CareQuest Institute for Oral Health for sponsoring today's webinar, and to the Indian Health Service Office of Clinical and Preventive Services Division of Oral Health for moderating the questions, and of course to our 3 distinguished panelists, Dr. Alice Horowitz, Dr. Catherine Atchison, and Dr. Jay Kumar for
Looks like Dr. Rick's camera has froze, so if we want to go to the next slide. Oh, Dr. Ricks?
Yes.
Okay, I just want to make sure I didn't cut you off too soon. Are you all wrapped up? You froze up
I'm
for a
wrapped
second.
up. I'm wrapped up. Next slide.
Perfect.
Yeah.
Great. So thanks again, everyone, for a great presentation, for sharing important information, and for your excellent responses to the Q&A session. Next slide, please. Before we end, we just have a few reminders. To learn more about our industry-leading research, we invite you to visit our resource library at carequest.org under the Education tab. We publish white papers, research reports, briefs, articles, posters, infographics, and tools on topics ranging from adult dental benefits to teledentistry. Next slide. As a reminder, please complete the evaluation form if you would like to receive CE credit. A link to the evaluation form will be emailed to you within 24 hours. Our next webinar on Thursday, October 20th at 1 to 2 p.m. Eastern Time will explore the transition to value-based care. Also, we want to stay connected with you, so please sign up for our newsletter to get more information on future webinars. Next slide, please. And here are a few other ways to stay connected with us. We invite you to follow us on LinkedIn, Instagram, Facebook, and Twitter. Next slide. That concludes today's webinar. To our presenters, we appreciate you for your contributions to the profession, and to all those who are present today, we greatly appreciate your time. We hope to see you on October 20th for our next webinar. Until then, wishing everyone a great day.